Hi, team. My name is Keith Lamb, and welcome to the next installment of RT CIMS or RT Complex Issues Made Simple. Now, if you've seen our other short presentations, you'll know that the idea here is to not get real granular and not get into a lot of detail, but rather give you a very high altitude overview of a topic that will then give you the information that you need to go out and look at this stuff in more detail. So that's what I hope you'll do with this topic. This topic is going to be mechanical ventilation on ECMO, a topic very near and dear to me. Somebody who's been a respiratory therapist for a long time. I have a deep interest in mechanical ventilation, and I have been involved in a lot of ECMO patients. So the overview. Basically, the rules of mechanical ventilation do not change. If a person's on ECMO for respiratory failure, they're on VV ECMO, then the rules that you should follow on the ventilator have not changed. They just become easier to follow. And so, what are those rules? As we remember, plateau pressure less than 30, driving pressure less than 15. Minimize the energy applied to the lungs, minimize that driving pressure, minimize the frequency that driving pressure is seen by the lungs. Still use PEEP to mitigate atelectatic trauma and to allow the use of the lowest FiO2 as possible. Permissive hypercarbia, what does that do? Permissive hypercarbia, not worried about what the CO2 is so much, allows you to use gentler ventilator settings, gentler driving pressure, less energy applied to the lungs. Same thing with permissive hypoxemia. People don't need PO2s in the 80s. Again, the rules simply do not change just because you're on ECMO. The rules are the same. They just become easier to follow. Now, if a patient is on VA ECMO because they are in cardiogenic shock or whatever the etiology of their shock or their heart failure is, then you need to worry about the RV, the right ventricle, and the LV, and how the nuances that pertain to VA ECMO may cause you to think a little differently about the ventilator settings. What do I mean by that? If you remember in VA ECMO, there's retrograde flow to arterial blood flow. It goes up uh, retrograde to the arterial flow. So in the case of that, if a person develops worsening respiratory failure because of this retrograde flow and because of the phenomenon, the north-south syndrome, uh, you may need to think about a different cannulation configuration uh, for that reason. That being said, consult your ECMO team, talk to them about this, make them understand that your ventilator approach is going to be a protective ventilator approach no matter what kind of ECMO that they're on. But get with the team, get with the ECMO folks, and talk about how you may be able to mitigate the negative influence on the RV or the LV. So again, hopefully this presentation will just give you a little bit of information. It's recorded. You can watch it as many times as you want. And hopefully you'll take the little bit of information that I've given you and go out and think for yourself and find literature that that pertains to this topic and read it and understand it and know it. Be the expert. Go to our website, www.inspire-rt.com. We have a resource page there, and you can find lots of papers on ECMO and protective ventilator management. And if you can't find something, message me on the app, and we'll get back to you with some answers. Thanks for watching, and hope you have a good evening.